Hi everybody. Today the topic of discussion is understanding the osteoarthritis of the knee joint and what a physio must be knowing. The knee joint is the most incongruent weight-bearing joint in the lower limb, and that's the reason why the degenerative changes happens pretty easily in the knee joint compared to the hip joint or the ankle joint. Though it is having a meniscal cushion, the meniscus itself is insufficient to provide lifelong immunity from developing osteoarthritis. The knee joint has to look after the locomotion as well as the weight bearing job. So, if any joint which is looking after both locomotion as well as weight bearing, I mean both stability and mobility, the structures will be very vulnerable and it can be easily injured with activity. Okay, the stability is also depend upon various ligaments compared to other ligaments in the body. The knee joint ligaments are many in number and they are pretty strong, like ACL and PCL and MCL. These ligaments are trying to provide reasonable stability to the joint, but these ligaments can try its best to provide the stability, but at times it can get injured, and that will secondarily produce instability related osteoarthritis of the knee joint. And the stability is also depends upon how the angles of the femur with respect to the tibia. Okay, we call it as a mechanical axis and the anatomical axis. These axes will also decide this inherent stability of the knee joint. The muscles try its best. We have strong muscles in the knee joint in the form of quadriceps and the hamstrings, one of the strongest muscles in the body. They also provide inherent stability to the joint. But these muscles are also secondarily governed by the mechanical factor, load factor, and the biological factor. So the muscles alone cannot do its job. Okay. So this is an example of how an arthritis can affect the knee joint. The knee joint has three compartments. We have medial compartment, we have lateral compartment, and there's a third compartment called patellofemoral joint compartment. So sometimes you get people having only the medial compartment osteoarthritis. Sometimes you get people who get only the lateral compartment osteoarthritis. Sometimes you get people who are having bicompartmental arthritis. That means both medial and the lateral compartment will get involved in terms of the degenerative changes. As you could see here, the meniscus is literally gone on both the sides. There's almost a bone-to-bone contact, and apart from that, you could see the osteophytic changes on both femur and tibia, both medially and laterally. Even the patella itself is not having a proper shape. So this is a classical example of bicompartmental arthritis. Sure, this patient probably needs a surgery. And now we have the third compartment called the patellofemoral compartment also is involved here. So when both medial, lateral, and patellofemoral compartment, all three are involved, it's called as tricompartmental arthritis. I would like to explain the differences between the cartilages which are lining the bone and the cartilages which are cushioning the joint. So the cartilage which is cushioning the joint is otherwise called as meniscus. It's a form of fibrocartilage. It is something analogous to the disc which is there in the spinal column. So it is quite a tough structure which is designed for shock absorption and weight distribution as well as weight transmission. The hyaline cartilage which is lining the cortical bone. You see here the smoothie layer here. This is called as hyaline cartilage which lines all the synovial joint. Okay, so this hyaline cartilage will get eroded and that will expose the periosteum. Remember, the hyaline cartilage is avascular and neural, so it does not have any capacity to produce pain until the layers of the hyaline cartilage is broken. A chip of the cartilage can break and that will expose the bone underneath, and that's the beginning of the arthritis. And once this hyaline cartilage, if it is damaged, it cannot be regenerated that fast. Maybe in the young age it is possible, but as people get older and older and older, the regeneration capacity of the hyaline cartilage will get diminished, and hence these people are more commonly involved. Whenever there is an arthritic changes, it's not only the hyaline cartilage which will get eroded, but also the fibrocartilage will get eroded. So that's the reason why in such conditions you could see if meniscus is almost gone when in the x-ray, as well as there will be a bone-to-bone contact. The moment there is a bone-to-bone contact, that's where the real pain starts, because the periosteum is highly innervated and that will produce pain as well as the subsequent inflammation. So this is an MRI view of the sagittal section of the knee joint. You could clearly see the distinctive hyaline cartilage that is lining the cortical bone of the femur, and also you could see the hyaline cartilage which is lining the cortical bone of the tibia, and between this hyaline cartilage we have the meniscus cushioning between the femur and the tibia. Now let's discuss the causes of the arthritis. We all know that the degeneration of the articular cartilage that causes bone to bone contact leading to pain, inflammation, deformity, and disability. It all starts as a simple pain, and gradually the pain will build up. eventually with activity it will get worsened. At some point of time it will cause deformity, maybe genuvarum, genuvalgum, and finally the disability. Now there are so many causes that are attributed to the arthritis. The first and foremost is the anatomical or the structural cause. Now the alignment is the core here. If the femur and the tibia are well over each other, then the joint stress is least. Sometimes people with excessive coxa or genuvalgum or genuvarum, the femoral and the tibial alignment will be not in line with each other. That causes abnormal excessive stress forces concentrated on one particular area that initiates the friction point that gradually lead to erosion of the cartilage in that particular point. So the anatomy or the structural factors play a role, and secondly, the load factor. Even if the anatomy is right, the load, sometimes people are excessively heavy, or they're occupationally having a job where they have to stand for a long period of time, or they have to walk for a long period of time. For example, the vegetable vendors who has to stand for a long period of time, the traffic police, or somebody who has to climb up and down 4 to 5 floors, almost like 10 years if he's doing, then this is called as overuse injuries, which can eventually cause the load related osteoarthritic changes. The third one is the trauma one. People who get fractured in their knee joint. For example, if someone gets a tibial condylar fracture here or a femoral condylar fracture, we call it as an intra-articular fracture. So any fracture which is happening within the joint surfaces where the hyaline cartilage of the tibia or the femur will get involved. In such cases, these cartilages may not regenerate properly, or it will regenerate in an abnormal manner. So that there could be an abnormal stress points concentrated into one single particular area that initiates the friction with the following inflammation and subsequent degeneration. So that's the reason why people following fracture, trauma, which is involving the articular cartilage, can easily get early osteoarthritis in their life. Even the ligamental injuries, for example, the medial collateral ligament injury or the lateral collateral ligament injury, or even the meniscal injury, these injuries can cause instability, and that instability can subsequently lead to early degeneration. Now, for example, if there is a meniscal tear in the medial aspect of the joint, the shape of the meniscus will be affected. So the space which was filled by the meniscus will be lost, and if, let's say there's a thinning of the meniscus. If there's a thinning of the meniscus, then the medial aspect of the condyle of the femur will drop down for about, let's say, 2 to 3 millimeter. If it is dropping by, that increases the concentrated force happening over this point. That will initiate the wear and tear process. Okay. So similarly, when there's a medial collateral ligament injury, it will cause valgus stress. So that in fact will increase the focal concentration forcing point over here that can incite or initiate the wear and tear process here. So whenever there's a ligament injury, because of its inherent nature of instability, that instability will cause abnormal joint forces which can produce the arthritis of the knee joint. The next one is a systemic problem. So don't think the arthritis is always degenerative nature. Some arthritis are inflammatory in nature. Okay. So what are the inflammatory arthritis? These are the conditions where there is a fundamental biological problem happening in the body which causes inflammatory cascade, and that inflammation will lead to degeneration. In age-related degenerative arthritis, the degeneration starts first, followed by inflammation. In primary inflammatory arthritis, the inflammation starts first, followed by degeneration. So, what are the inflammatory arthritis? Your classic rheumatoid arthritis, your ankylosing spondylitis, your psoriatic arthritis. These are the types of inflammatory arthritis which affects any joint, not only the knee joint, it can also affect any other joint. But the hallmark is in rheumatoid arthritis, there will be a bilateral symmetrical symptoms. It starts with a small joint pain and then it can go to the large joints, or rarely it can directly go to the large joint. Apart from that, there are other conditions like TB or septic arthritis or hemophilia. These are all other infective or the metabolic problem that can lead to the degenerative cascade of events in the knee joint. So, but these conditions are very rare. A majority of the arthritis are degenerative in nature, especially when it is happening for the old people beyond 50 years. 90-95% of the times, these are all degenerative arthritis, not the inflammatory arthritis. And all these arthritis, they have a genetic predisposition. Now, some of my patients tell that, doctor, my mother was having arthritis, my grandmother was having arthritis, so I think I am also having the same arthritis, because the body types are shared between generation to generation. Their tibiofemoral angle, their anatomical axis, their pelvic girth, okay, all these things runs in family. So that's the reason why there's a small genetic link for the arthritis. These are the causes of the arthritis. Of this, the anatomical, structural, and load are the common causes of arthritis when already someone is having a genetic predisposition. So, if someone is genetically predisposed with anatomical and structural factors, the load plays a role. That's the reason why the load is to be managed. The load is a modifiable risk factor compared to your genetic and anatomical factors. Now, let's go through the anatomical and the mechanical axis. Now, what is anatomical axis? The line which is drawn along the center of the shaft of the bone is the line through which the anatomical axis fall. Where is the mechanical axis? The mechanical axis starts from the center of the head of the femur and it runs all the way down up till the middle of the talus. Okay, so this is how the line of gravity pass through the joint. Now, it is this line of gravity which will decide where the joint stress will be more concentrated. Now, ideally, you know that for the normal knee joint, the line of gravity should pass through the center of the knee joint, not medially nor laterally. But in this case, you could see the line of gravity is passing medial to the joint. So, this will predispose to medial compartmental osteoarthritis. So, you see here, now let's say the first one, let's say this is femur, this is tibia, this is talus. Life will be very easy if the line of gravity is passing through the femur and the tibia and the talus, but that's not human beings are designed. All our bones are bent at angles, isn't it? So you see here the head is here and the shaft is here. We have a neck shaft angle and then we have a medial knee angles. So even when there is a surgery happening, the surgeon will be exactly calculating all these anatomical axis and the mechanical axis and make sure that the process is fixed in such a way that the line of the mechanical axis is passing through the joint. So that's a very important consideration when they do the knee replacement surgeries. Okay, so to understand, the line of gravity passing through the center of the joint produces least stress in the joint and less gravitational torque. When the line of gravity is going away from the joint, let's say you see this picture, when the line of gravity is passing away from the joint, now there will be a compression force here, there will be a tensile force here. So this patient will have the compartmental arthritis in this aspect. This is one more picture that clearly elaborates the same. So this is the genu varum tendency where the line of gravity is passing far more medially to the joint axis, and this causes excessive compression force in the middle aspect and tensile force in the lateral aspect. You see in this picture, this is genu valgum where the line of gravity or the mechanical axis is passing lateral to the joint axis, and that produces excessive joint compression force in the lateral compartment aspect of the knee joint and tensile force over the middle compartment. And this is the one is a normal line of gravity where the line of gravity is passing exactly through the middle of the knee joint and to the middle of the talus bone. Okay, now there's a small addition here. There are people who have tibia vera. The knee joint angles will be normal, but the angulation will start at the tibia level. So these are the people who are having excessive tibia vera. Again, this is one of the genetic predispositions. Some people will developmentally will have excessive tibia vera. Okay, and such people will have excessive compression force over the middle joint compartment. Okay. Here are my patients. You could see this patient, she's having the genu valgum tendency. So where the mechanical axis will be, the mechanical axis will be lateral to the knee joint. So obviously there will be a lateral compartmental arthritis. So it damages the lateral meniscus. It can cause the thinning of the hyaline cartilages in the lateral compartment of the knee joint. Whereas you see this patient, she's having genu varum tendency. The mechanical axis will be passing medial to the joint axis that produces excessive joint compression at the middle compartment of the knee joint and tensile force in the lateral compartment of the knee joint. Okay, so now both patients met me with a knee complaint, but one had lateral compartment OA and one had middle compartment OA, and one patient had severe joint narrowing along with the meniscal damage. Now this is about the standing X-ray of the lower limb. Okay, in order to clearly understand the mechanics of the osteoarthritis, it is recommended to have the patient take standing X-ray, because in standing X-ray you will see the entire length of the femur as well as the tibia, and since the patient is weight bearing, you will realistically know how much is the joint compression is happening, because when the X-ray is done in supine lying, there is no weight bearing happening in the knee joint, so you will not be able to realistically predict how much is the joint compression happening. Now in standing, the entire body weight is on the knee joint. So whatever you see as the joint space is the space which is due to the presence of hyaline cartilage or the meniscus of the knee joint. Okay, so the integrity of the meniscus as well as the hyaline cartilage can be easily viewed in standing X-ray. Now, weight-bearing X-ray is a realistic way of measuring the joint space. In standing X-ray, it's easy to draw where the line of gravity is passing through. Okay, so what are the clinical features of the osteoarthritis? Now it's hugely variable between people to people. We go by the history because these people doesn't go to the doctor on the first day itself. The pain starts and then they wait and watch. They do some home treatment, and then they rest. They apply hot pack, cold pack, and then they'll be all right. Again they do some activity, and that will increase the pain. They'll wait and watch, and maybe for the third time or the fourth time if the pain repeats, then that's the time they usually consider to go to a doctor. So the history will be hugely variable, but people say that it was starting gradually, and then at some point the pain become constant, and it increases more in intensity, frequency, as well as the duration. And usually these pains will be exacerbated with activity, especially when they stand for a long time or walk for a long time. When they go out of station, when they have to walk somewhere outside, that's where the pain usually kicks in. The locality of the pain depends upon which compartment is affected. For example, if the knee is affected in terms of the middle compartment, their pain will be more localized in the middle aspect, sometimes in the lateral aspect. Depending on the patellofemoral joint, if it is involved, the pain will be localized on the anterior and the superior aspect of the knee joint. So the patients, as I said, usually will be taking symptomatic treatment. They take rest, oral pain medications. Every house will have one or the other gels and ointments that they apply, thinking that that will reverse their pain. But eventually, the inevitable will anyway happen. Some patients, when the meniscus is torn, they'll start hearing the clicking sound or the locking sound, and when the meniscus is completely gone, then there will be a grinding sound that they can hear. Even the physios, when they're doing the examination, they can hear the sound like clicking, locking, or grinding. Now, how the range of motion will be? Again, this will be hugely variable. Some people will have good range but extremely painful. Some people will have mild restriction but pain will be less. Some people will have very severe range restriction with severe pain. So the spectrum is quite varied, but range of motion in terminal stages will be restricted, especially both active and the passive range will be restricted. Beyond 110, 120, it will be usually difficult for these patients. Okay, and the end field will be empty end field, because the patient, when you're doing the passive range of motion, as you bend the knee joint or extend the knee joint, because of pain, the patient will not allow you to go through the end range. All right, now painful tight muscles is one of the hallmark of arthritis of the knee joint. So these people will be showing their medial hamstrings and the lateral hamstrings, sometimes the calf muscles, or even the top of the quadriceps will be painful and tight. Okay, and of course, since there's an inflammation going on, there will be a definite warmth in that area. And if it is not a bilateral arthritis, and check with the other side and see how much warmth you are feeling in the affected side. The pain will make them slowly stop moving their joint, and they'll limit their activity, and slowly their gait pattern also will change, and finally it will lead to deformity. So these are the sequence of events that they will get. Okay, diagnosis is not that difficult. People who are beyond 50 years old with a history of gradual onset of pain, and pain exaggerated with the activity, especially walking and stair climbing. In classical osteoarthritis, activity will worsen the pain and rest will make them better. Okay, excessive walking or excessive stair climbing, that will immediately exacerbate the pain for the next 1 or 2 days. The pain pattern, as I said, the pain pattern will be localized, dull, sharp during the movements, but the pain can go up to the middle of the leg, or the pain can go up to the middle of the thigh, but these pains will never go down to the foot. Okay, remember, people who are having discogenic back pains, they also do get knee pain, but such knee pains will be different in characteristics. Like it will be more like a sciatica type of pain with SLR positive and slump test positive with tingling and numbness. So don't get confused with the sciatica related knee pain with the osteoarthritis knee pain. And rarely, sometimes, to confuse us, people will have both osteoarthritic pain as well as the sciatica pain. That will be quite challenging to diagnose and treat. Okay, but still, if you pay keen attention on this information, you'll be able to pick up who is having sciatica type of knee pain and who is having osteoarthritis type of knee pain. On observation, there could be an obvious swelling because there's an inflammation going on, especially when these people are having the history of like 5 years or 10 years of arthritis knee. Definitely swelling will be a hallmark sign. Okay, on palpation, definitely every physio must be palpating to get to know the tenderness level, which joint line is more involved, how much is that tenderness in the muscle level. So that will give you an overall idea of the overall irritability of the patient. So do know how to palpate the medial joint line and lateral joint line, and palpation of the quadriceps, vastus medialis, lateralis, calf muscle, head of the gastrocnemius. These are the important landmarks that you have to palpate. Examination, do passive range, do active range of motion first. Get to know how much is the range happening. Usually, extension will not be greatly affected, but flexion is the one which is largely affected in most of these patients. Anyway, nowadays people are not using Indian toilet or are doing squatting, so invariably people are losing their range of motion towards flexion. But in osteoarthritis knee, the flexion range will be even more limited. So beyond 90-95 degree range, in chronic OA, there could be a pain, and the pain locality also will decide where you have to probably treat. In the pain, if the pain locality is more in the anterior aspect when you are bending the knee, you have to probably treat the anterior aspect of the soft tissues. When the always do the patellar glides, because even in patellofemoral joint arthritis, the patellar movements will get restricted because of these patients are not using their joint normally. The patellar movement will get restricted. So you have to glide the patella medially, laterally, superiorly, inferiorly to make sure that the patellar movements are happening normally. Imaging is done to confirm the diagnosis. Especially there is no special test to the diagnosis of the osteoarthritis. It's always confirmed by the X-ray or the MRI. So with your positive history and the X-ray confirming it, you can diagnose it as osteoarthritis of the knee joint with high confidence interval. Now this is the knee. This is what you see in the X-ray. This is a normal knee joint. You have the patella sitting nicely in the center of the femur. No osteophytes whatsoever, and you could see the lateral joint space. Now you see this space. This space is filled with meniscus. That's why it is not shown in the X-ray. So X-ray will pass through the soft tissue, and hence you are seeing the gap here. So in the normal joint, you should see a nice gap here. You should see a nice gap here. Both gaps should be reasonably equal to each other, and then you can see the eminences here, the head of the fibula, tibiofibular joint, and there is no osteophytes whatsoever. The joint lines are clean. There is no breakage there. There is no loose bodies there. The alignment between the femur and the tibia is perfect. So this is an example of a normal knee joint. So you should know what is a normal knee joint will look like, so that you will pick up the abnormal X-rays in these patients. Okay, so for your understanding, these are the normal landmarks. You can take a screenshot and then you can keep it for your reference. Okay, this is a lateral view. You could see the patella here, and then in terms of patella alta, patella balja, you can see the abnormal positioning of the patella. You also see a sesamoid bone here called fibula, which is easily seen in some patients. All right. So the X-ray, is it all? No, the X-ray does not show how much pain the patient will be having. We had seen some patients with terrible looking X-ray, but the pain was absolutely nil. We had seen people with mild arthritic changes in the knee joint, but the pain was severe, and that's where the biology makes a difference, and the inflammatory tendency of the individual body will make a difference. So, but we correlate. When the patient is also having the symptoms positive, with the X-ray is showing the degeneration of the joint, then we diagnose it as an arthritis of the knee joint. Okay, so mild, moderate, severe, there are so many gradings into that, but let me not dwell deep into that. As you could see here, when there's a direct bone to bone contact with severe attrition with osteophytes, we call it as a severe arthritis. Now coming to the important part, what is the management? Now it's very tricky, because there are so many factors play a role here. When we talk about the mechanical factors, we can talk about exercises. Now you can strengthen, as a physiotherapist, you can strengthen the quadriceps muscle, the vastus medialis muscle. You can release the hamstring tightness. You can strengthen the hamstring muscles. There are so many exercise programs intended to strengthen the muscle. But is it all the strength which is a problem here? No, strength is one facet in the overall picture here. But it's good to have a normal muscle strength. But usually in osteoarthritis, because of pain, because of the inflammation, the muscle will inhibit itself. So it's the pain and the inflammation that makes the muscle weak, rather than having the weak muscle causing the osteoarthritis. If you see people who are paralyzed, let's say polio or quadriplegics, they have very weak muscles, but they won't get any arthritis. Even hemiplegics, they will have paralysis of the entire leg, but they won't get arthritis. When there's a pain ongoing in the knee joint, that can silently inhibit the muscle function, because this is called as reflex inhibition, where when there's a pain in the joint, it can cause weakness in the muscle. So as a physio, you should always aim to strengthen the muscle. Look for the length deficiency in hamstrings or the calf. Aim to increase the range of motion of the joint if it is limited, but you should always see the bigger picture. Sometimes weight relieving braces will be very useful, and for people who are having middle compartmental arthritis with genu varum, or lateral compartment arthritis with genu valgum, sometimes we give weight relieving orthosis like this. These are all custom made, which creates a big hole in your packet, but there are some cheaper versions available in Amazon as well as in the local orthotic shops. Some people who are having foot problem, like flat foot, the knee joint sometimes can be contributed because of the abnormal foot alignment. So in such cases, the footwear modification is essential. So we discussed on the mechanical factors. Let's talk about the biological factors as well, because this is one of the reasons why some people who are having terrible looking X-ray and still they will not have no pain. Why? Generally, their overall inflammatory response in their body is very less, and that makes every individual different in terms of the inflammation, in terms of the swelling, in terms of the pain, because how the body reacts to the wear and tear is decided by your biology, not only by the load factor or the mechanical factor. So if these people are already having an inflammatory tendency, or even in conditions like diabetes mellitus, thyroid problem, or metabolic syndrome, these are the instances when the body will be easily inflaming. So, and the load factor. So, this is the most easily modifiable risk factor in terms of the overall management of the joint. Now, for example, if you are a teacher or a traffic constable, then the risk is quite high. So, you can talk to your authorities and get transfer job, or a workstation modification where you can reduce the load factor. And housewife who are standing in the kitchen for long period of time, you can put a stool inside the kitchen, and every now and then you can go or unload your knee, and then you can come back and work. And weight loss is the most important thing. It's very easy to say to lose weight, but it's not that easy to actually implement. Okay, it's actually a vicious cycle. People who are having excessive body weight, because of the weight they got the knee pain. Because they're having the knee pain, they're unable to walk, and the doctors will say that to and doctors will say to lose weight, and they will not be able to lose weight, because to lose weight they have to walk, but walking will increase the pain. So they'll get stuck, and they'll get stuck there. And this is the time where they can really think about dietary modifications, especially the intermittent fasting or the low carbohydrate diet, by which they can lose the body weight without even the physical activity. So even if they lose about 1 kg body weight, for example, if there is a reduction of 1 kg of the body weight, there will be equal to 4 kg of reduction of the knee joint stress. That means if someone walks 5,000 steps in a day, with 1 kg loss, they'll be enjoying at the end of their 5,000 step. Okay, see, it's all about wear and tear. Why? Because the load was more, the tear was more. So you reduce the load either in the terms of the weight that you impose on it, or the rest that you give, plus here and there some strengthening exercise you can do. But load and the mechanical factors are the huge one that determines the improvement of these patients. So that's the reason why we talk about rest, because when there's an ongoing pain, and if we keep on walking, and not giving any time for recovery of the cartilages, and you're going to worsen further and further. Okay. Finally, you need to educate the patient, because some of the patients will have wrong notion about what is osteoarthritis. So they think that if they walk more and more, they'll be all right. Some people will hate to take rest. Some people will hate to go to exercises. Some people will keep on relying on native treatment like oil application or massage. But you need to educate about the patient about the knee joint and why they got arthritis, what are the factors that played a role, and the adaptability of the body, how exercise is going to help them, how load modification is going to help them, and education about weight loss, diet modifications, and exercises, all will be very, very handy in terms of the overall management of the arthritis. And finally, in extreme cases, so in my practice, I don't cure everybody, because some patients really need surgery, because by the time they meet me, they would be already in the terminal stage that I cannot do anything about my physical therapy intervention to them. So in such cases, I wisely send them to the surgeon. You see here, one of my patient, he is a vegetable vendor. So he has been selling vegetables for the past 25 to 30 years, and he got the pain long back. About 20 years back only he got the pain, and he didn't go to a doctor. He took some oral medications. He took topical agents. He did all sorts of treatment without consulting a doctor. Finally, now he is not able to walk even more than 50 meters, and he was limping. Pain was too much, 8 by 10, and there you could see there's a marked varus deformity. And we saw the X-ray. There's a classical middle compartmental osteoarthritis. You see here, there's a real bone on bone. Now, at this stage, this patient has to anyway undergo the surgery, because there is no turning back now. Okay, no amount of exercises or any calipers will reverse this pathology. Okay. Patients with arthritis will have combined manifestations of metabolic, mechanical, physical load, and his attitudes and beliefs and expectations all will decide, okay, how the overall management is going to work on him. Now, as a physio, you must know the intricacies of everything, because we can talk about exercise for the entire day, but it's not only about the exercise. You need to talk about the load factor, metabolic factor, inflammatory factors, and so on. All will decide the overall outcome of the treatment. Now, physios must know the intricacies of all the factors and decide the right recipe of the treatment. Now, exercise is very important in the overall management of arthritis. I didn't go into the intricacies of what exercise somebody has to do, because every patient's presentations are different. Sometimes I treat the vastus lateralis, sometimes I treat the calf muscles, sometimes I treat the gluteal muscles. So sometimes I give tape, sometimes I tape the patella. So the exercise itself is quite varied between people to people. I'm not going into the intricacies, because that is individualized, but do understand that one size does not fit for all the patients. So the physio must be choosing the best treatment for the given condition. Early identification and intervention prevents future deformity. But this is the mistake that most of the patients are doing, that when they get the initial pain, nobody cares about that. They wait and watch, they allow it to worsen. By the time they meet the doctor, the condition is already in the irreversible state. Okay, so make sure that you don't go to that level. Probably meet the physiotherapist very early. When you get the first pain or the second episode or the third episode itself, you try meet a physiotherapist, so that at least if there's a chance of preventing the future deformity, why not to use it? Okay, the most important thing is diagnose the condition correctly. There are so many other conditions which can mimic like osteoarthritis, and some of these patients are wrongly diagnosed as osteoarthritis, wherein it could be a something else. It could be a patellar it could be a MCL sprain, it could be a mucoid meniscus, or it could be a osteochondritis dissecans. So there are so many there are n number of conditions that can mimic like osteoarthritis. So only an experienced physical therapist or the orthopedician can really pick up the right diagnosis. So make sure that you rule out the other conditions when you are diagnosing the osteoarthritis. I do a lot of soft tissue treatment, right? Dry needling and myofascial release and so on, plus exercises. But these are all to be used as an adjunct. They are not the core treatment, because the core is the overall understanding of the problem. If you know the nature of the problem, you can decide the best treatment. I hope you got a little bit of what I wanted to say. Thanks for listening. I'll see you again in the next video.